You should open.
Thank you, Domenica. Yeah, I was muted. Thank you, Domenica, for this presentation. Thank you for organizing every 15 days these webinars that are very important to have a look at the situation of the rare diseases in all over the world. So I am very happy to have today Spain, because we are very close to Spain also with our federations, and England too, UK, and Barbara Yugonin is so clever, so good, and so fond of rare diseases. And I can see also Marco Macucci, that is very active in the field of rare diseases. And so I think it's very important to go on with these webinars and to disseminate the knowledge of the rare diseases also in Italy. And I am very happy to speak again in Italian from the next time. So no one will, other people could understand better what we are saying in all these webinars. Thank you a lot, and welcome everybody, and good listening.
Thank you so much, Annalisa. So, since I don't see Dr. Beatrice Lara, she's a medical doctor working really in clinics, and so maybe she has some problem, because we organized everything, and just half an hour ago she was online, so maybe she will come back soon. It's also my pleasure to say to Dr. Marco Macucci, welcome to. It's not the first time that he can join us in these webinars, and I would like to invite you, if you wish, you can use the chat to send, or you can also use the hand. You see, alza la mano, so we can interact as much as possible due to the platform, the video conference platform. Unfortunately, we cannot have these meetings in a face-to-face way, unfortunately, but at least we can interact through this chat and the hand. So then, in the meantime that we are waiting for Dr. Beatrice Lara, maybe she is busy with some patient, we will check. I would like then to give the floor to Alba Diaz and Elvira Martinez. Alba is the president of the federation, the Spanish Federation on Rare Diseases, and Alba and Elvira will speak about the experience of patients in Spain during the pandemic and after, let's say, still now. Further, congratulations, because this is a very important year for you. Sure, you will tell us, because you are now, let's say, adult. You have 20 years. And congratulations, you are very, very active, not only in Spain, but also in Latin America too, with an additional. So we are really willing to learn from you and to listen to you. So please, the floor is yours, Alba, and then Elvira.
Well, Alba, can you hear me?
Yeah, Elvira.
Great. Yeah. This is Elvira from the Spanish Federation of Rare Diseases. Thank you so much. We are delighted to be here today. Alba cannot join us right now. Let's see if she can join us a bit later due to her agenda, super tight agenda. But, well, I'm here because I work on advocacy and also in everything related to international relations. So I can tell you a bit of what we have been doing during this horrible pandemic last year, how we faced it and how we are facing it right now. I don't know if you want me to start with the presentation or we wait.
Please. No. Yes, please go ahead, Elvira, okay. With your presentation.
Then here it is, because it's not me who is sharing the presentation. That's why. Well, thank you so much. We can go next. Yes, thank you. We structured it because of the way we reacted. So we realized there was a pandemic, a real pandemic. Then we said, oh, we need some data, what's going on? Then we faced actually the pandemic, and then we are looking ahead. So let's see. Go next, please. Next. Here we are. First of all, what we needed to do, what we always do, is to know what is happening. So we were surprised as everyone. And the first approach should be thanks to data, thanks to the information we can easily collect through our main services. So we collected the information mainly through our information and guidance service, which is called in Spanish CIO, where we could contact with over 600, almost 700 cases, people who needed our help in some way. Of course, also through our psychological service. And this is the way we realized that the three main points that were a real issue, a real concern for our collective were the education, legal consultations, and also social and health inquiries. That's what we had at the first stage. So we can go next, please. So this way, we already knew some unmet needs, some concerns that were key to our people, and we continue discovering and collecting data through other studies. For example, the well-known Rare Barometer Voices. We collaborated, we worked on it also, and this way we could know that we were not alone, but also Italy and Poland were the countries with the greatest impact. We had the same problems, more or less, interrupted care. Sorry, one moment. Please. Chicas, por favor. Chicas, estoy en una reunión, por favor. Sorry. So, this way we could know that Spain, Italy, and Poland, we were in a huge difficulties. With the disruption of rehabilitation, the care interrupted, and having a major impact. Next, please. By the end of the year, we could nail out a bit more what was what happened with our collective. So figures are not good at all. As we can see, 8 out of 10 persons with a rare disease had to leave their appointments. They had their rehabilitation therapies interrupted. They couldn't reach their clinicians, etc. It's not easy. As well, we did a specific study focused on education because it was one of our main concerns in Spain for people. And I don't have figures about it, but it's quite similar. The problem was also related to children that couldn't go to a school, couldn't have their treatment, and couldn't have relations to their colleagues. So we go next, please. And then next. So now we had all this data, we had to react. And first of all, we have to react ourselves with our organization. We changed the way we work. We became working online. Here you have the picture of some of our colleagues. So we changed everything regarding our organization, meaning individualized measures. So flexibility with time, flexibility with reconciliation. We had to undertake financing challenges. We developed a contingency plan for activities because we had a lot of activities that, of course, were cancelled or changed. We adapt our infrastructure to prevent measure, and we had to change our internal communication, which actually was a great achievement because we changed it for best, and we are now working in a different way, which is much better. So we can go further next. Please. Thank you. It's okay. So what we did, we focused on direct and specialized service, especially what we called CEO, this service that is direct to people living with a rare disease and their families. So we located over 50 resources, specific socio-health, legal, and educational resources. We had a lot of videos for our collectivity, and we tried to encourage participation in national and international studies, as we said before. Next. Also, what is very important for us, it's SAP. We called it this way in Spanish, but it's the psychological service. As you all know, the emotional impact of the pandemic was a huge part, and in our collectivity of rare diseases, a bit more even. So we developed psychological care workshops about emotion management, emotional intelligence, but especially focused on this special situation of being at home alone sometimes, and also empowerment workshops focused on good practices and how we could all face this situation. This way we were able to help over 200 people through over 30 entities, so it wasn't that bad. We needed more, but it wasn't very good for a lot of people. We also had a lot of consultations. Our psychologists were working more than ever, so we had over 600 consultations to help all these people. We can go next. Then we had to focus also on our entities. So what we mainly did was to focus on prevention and safety of our associative movement and improve and help them improve their services, and also family ed, meaning home care and therapies, and also technological resources. We will see it a bit later on. We go next. Great. So, as we said, this social attention was more necessary than ever. So we created and we were part of a direct communication channel with the Directorate General of Disability, which is part of the Spanish Ministry of Health, via WhatsApp. In this context, other important platforms in Spain, like translated, it would be third sector platform. We needed to denounce the decision of the Ministry of Health of cut funding of our NGOs, and we joined forces, and it worked quite well through specific actions of political advocacy. This joint work was also with other entities like CERMI, which is focused especially on disability for reconstructions and rebuilding measures. We can go further. Next, please. Yes, thank you. The same way we accompany and give advice to our entities and providing tools. These tools were quite important. Maybe they seem simple, but in the end they were key, actually. They were not only online seminars, all these webinars, we are like this one now, for certain needs, these unmet needs, and also talking together find solutions, but also boosting technological support, because some of our associations, and a lot of them, they need technological platforms and they didn't have them, and they need some voting apps, and this was very important. And also we organized a call for grants, which was key also for our movement. So we go next. Also, our focus was on socio-educational and labor approach. Why? Because we needed to act against isolation, especially focusing on children. We realized which were the main needs for our families. So we organized specific aids to facilitate these digital resources, so they could access to distant education. And also we organized specific projects for alleviating the isolation of minors, because in Spain, for a long time, minors couldn't go out, and it was pretty complex for the minors with a rare disease. So next. Then, thank you. Then we already mentioned it, but it was a great achievement for us. We managed to organize extraordinary aid funds, boosting specific protection and safety aids for the entities that are part of our federation. So this way we were able to organize 45,000 euros in two modalities. One for entities that provide therapeutic services, but also projects for families that needed technological or therapeutic support at home. So go next. As you all know, awareness is key in every sense. So visibility was pretty important for us also. So we worked a lot on this with a double campaign and a double goal. One, positioning ourselves as a reference entity for families and for our entities also, and as well putting the issue on the public agenda, because all the initiatives we were hearing about was focused on health in general and on the pandemic, but suddenly there were no rare diseases on the public agenda, so we needed to find a way to put it there. So we had 500,000 visits to our microsite, which was especially focused on COVID-19 and the Rare Diseases Collective. And also we were able to publish over 60 news, and we had the cover of media that are key in Spain. So it was a great achievement if we think how difficult it was at that point. So it was a great work for our communications department. We can go next. Regarding advocacy, we knew we had to do a great work, and we started by developing our 5 main positioning documents, our 4 main problems. So we had an initial positioning, which was need, also the emergency measures, then the urgent action for the de-scaling for people with rare diseases, then the it's difficult to because it's a word game. In Vulnerables report, it was related to how we are a vulnerable collective, and we don't want to be so vulnerable. So it was a report focused on key data and achievements that could change everything. And then finally, the 15 priority actions to keep in mind. At a local level, a local level, we worked with two of our main partners in Spain, and we find the way to alleviate the confinement of minors and some benefits that are key for our group of people, and especially some taxes. And also the way of working on home treatment and treatment of people with rare diseases and chronic patients. So it was pretty useful. Then we worked also with international movement, as you can see there, with the Rare Barometer Voices, with Aliber in Iberoamerica. So we were working also on Rare Barometer Voices, but there, and dissemination and positioning, and with the RDI, with international declaration. We can go next, and it's the end. Then go next, please. So, what we learned of all of that. First of all, and the most important thing, we have to collaborate, to work together. We knew it, but it became completely evident. The importance of telemedicines and information technologies was key, was evident. We were asking for that for a long time, and now it became obvious that it was a need. The home treatment, the social movement for prevention and for finding solutions, how important research and health efforts are to find a structure that allows diagnostics tests, the autonomy and resources to give continuity to therapists in any way, in any situation. And especially, and what we value the most, the continuity of the activity of the associative movement, which was not only us, but a lot of organizations. So this is how it worked for us. I don't know if there are any questions in the chat, but I didn't see it.
Elvira, thank you so much. I can help you. It's interesting what you said. It's very interesting.
There was too much noise. I know. I asked my colleagues to silence. I'm sorry. We are in an office, so I'm not alone. I'm sorry.
Yeah, no, I understand. I know your place because I came, you remember 2 years ago, I think, with Anthony Montserrat. And I'm very pleased to see Tony here. And during the discussion, if you don't mind, Anthony, we will invite you for actually we will invite all of us in order, here, Anthony, it's a pleasure for us. So I would like to spend a few words about Tony Montserrat. You are the father of rare diseases. So, as you know, I'm very pleased that you are here. And he worked a lot, many years in the European Commission. And he was really at the beginning of the start activities on rare diseases. So, please, Anthony. I'm very pleased. This is a webinar among friends. Although we are, all over Europe and there are also colleagues from, there is Emilia, Professor Severin from Romania, and also other colleagues, other friends. So please, Tony, it's really informal, and we would like really to continue the spirit that we start together, a community. We are a community. So let's go ahead. Please, Tony.
Well, by surprise. Okay, I suppose I can tell that we are in a very different situation as we were practically 20 years ago when we started to work in the area of rare diseases. That's absolutely true. From one side, from positive things and with very bad things, we can say. Well, what I can tell you is that really 2020 was a tragic and tremendous year in all terms, personal terms for every one of us. But it was a year extremely productive from the side of the European institutions in terms of giving new instruments for the community of rare diseases. From one side, we had the approval for the first time of something that we can tell a real health program for the European Union, with the new EU for Health program, with an amount of 5.1 billion of euros, which is extraordinary, because Domenica, you know very well that during years and years we were used to work with a program with 300, 400 millions of euros. Now we have practically 12, 13 times more budgetary capacity. And that is, I think, an extraordinary new for the community of rare diseases, for the whole community. It's not the only positive thing. We had also during 2020 the approval of the cancer beating plan, which is an extraordinary instrument also with an enormous budgetary capacity, and having also a chapter specific for the rare tumors. And I think this is a second very important news. It was also the year in which we proved that this approach, call it centralized acquisition of medicaments, it was something that could be useful. Well, it has been certainly used in the case of the vaccination for COVID, but that opens also an extraordinary possibility for the acquisition of the orphan drugs in order to reduce the prices for the whole European Union. I think it's also a third very good news. The fourth very good news during 2020, it was certainly the final report about the orphan drugs regulation and the pediatric regulation, also opening the possibility for the reform and the update of this regulation. I think that as a whole, these are very good news from the side of the European Union. Things that are now under discussion, of course, from the side of EuroDis and from the side of patients' organizations, we are certainly beating at this moment for an approach for the first time in the newborn screening, which is absolutely necessary. And here we are experiencing, unfortunately, barriers and problems and difficulties with the European Union in order to advance in this line. We have also difficulties for advancing in the consolidation of the European platform for rare diseases registration, which is located in Ispra, here in Italy. And well, I try to summarize that 2020 was a very strange year for every one of us. Some of us, unfortunately, we lose members of our families. We had, a very difficult year in familiar and personal terms. But if we see what was 2020 for the people suffering from rare diseases, it was a positive year. That's the reality. And of course, after there are all the things related directly for how COVID-19 has affected patients suffering from rare diseases. Elvira has given an excellent explanation about the Spanish situation, which is, I think, something that we can probably translate to other countries. We have everywhere experienced this type of problems. We have been seeing how treatments, diagnosis has been delayed, or how we had situations that we were completely unexpected for every one of us. But what the speech from Elvira proves and the experience of Teder proves is the extraordinary capacity of the patients' organizations to react to unexpected situations. Nobody was prepared for this COVID. Nobody was prepared for these pandemics, but the experience of FEDER as experience of UNIAMO and other organizations proves very well the capacity that we have by chance to react to these type of situations. And I think, well, you asked me a little to do my reflections like this. I tried also to summarize some points. Of course, I am always convinced that we are in a very complicated situation. Next month, we have the EuroDIS membership meeting during 3 days, 12, 13, 14 May. And we will probably introduce new elements, new things that it's necessary to do, because unfortunately the fight from the rare diseases community is a fight for a lot of years. And it's a precious treasure that we have people like you, Domenica, helping, fighting, and every day innovating in the fight and the combat for giving to the person suffering from rare diseases a hope. And this extraordinary combination of people like you, Domenica, and people like Elvira and Beatriz and others in FEDER, I think it's really a hope for all the persons suffering from rare diseases in Europe.
Thank you very much, Tony. Please stay with us, because I would like really to interact with you during the webinar. Especially you mentioned the newborn screening. In fact, we presented the position paper in one of this webinar, and Simona Bailagamba so she presented it. But I would like to give the floor, thank you so much, I would like to give the floor to Beatriz Lara, because I know that she's between two patients and she's in clinics, so very busy. Elvira, if you can stay with us, then at the end, we can, after Barbara, we can open the discussion. And please, Beatriz, I'm sorry, but I know that you have some problems. Please, go ahead. So I introduced you before. So you are a medical doctor and you are working on the respiratory medicine department in the UK. But please, you can, of course, tell us more. Please.
I'm sorry that I was not ready on time due to some technical
don't worry.
So thank you for inviting me. My presentation is debut from a chest physician working in the really front line of COVID. Apart from my interest in rare respiratory diseases, so I just would like to do a few details about what we have been through, and also some reflections about how the COVID pandemic has impact in our daily work, and also some positive features about that and how that has impact in our patients. So if you see the summary of my presentation here, can I have the next slide, please? So as you know, the first wave in the UK arrived later than in Italy and Spain, and we didn't achieve the same number of cases that we have. So we're a little bit prepared and learning from Italy and Spain colleagues what was about to come to us. But from November and December, with the arrival of the new variant that is now hitting the rest of Europe, we have a very strong second wave, and that was even worse than in March of April. Next slide, please. With a peak of cases admitted in hospital, close to 40,000 in January this year. That has changed the whole way we were working in inpatients, and also outpatients, with all the outpatients clinic cancelled for a while, and really problems with capacity of beds in hospitals and basic things like oxygen supply in our buildings. So I know you are probably fully aware of the situation that we were living all over the world. Next slide, please. That has had a huge impact also in the number of deaths. So respiratory medicine is mainly about chronic lung diseases, and lung cancer has a high mortality. So respiratory clinicians are quite used to see patients dying. But in this pandemic, the number of deaths that we have to deal with in our wards has been probably triple or quadruple the standard death rate that we have. And that has not only been a tragedy for our communities and our families in some cases, that has had a huge emotional impact in the workforce. Next slide, please. Thankfully, we have a vaccination, and this is a great success for science. And the vaccination program in UK has been very successful, as you know. And for me, this vaccination is like a miracle. So now the incidence has dropped. The number of admissions has dropped to more than 90% in the last 6 weeks. So now we have a very, very small number of COVID cases on our wards. So I really want to transmit that hope to the countries that don't have they have not progressed so far with the vaccination. It's really, really an excellent vaccine, and we are seeing a real change in the trend. Next slide, please. So in terms of how this pandemic has impacted our patients, Public Health England published a recommendation for shielding for patients with chronic lung diseases. The patients were receiving a letter from the NHS recommending to shield, and that give us the support of being working at home or staying at home of work for their employees, and also giving some access to services that they were risky to have. So, for instance, home delivery from supermarkets and special access to certain services. And most of the rare respiratory diseases were included in this Public Health England recommendation for shielding. All chronic long-term respiratory diseases as asthma or COPD, but most of the chronic rare diseases, cystic fibrosis, pulmonary fibrosis, even sarcoidosis were on that. And the shielding recommendation also include patients on immunosuppressants, and most of the respiratory rare diseases will be within that category. That has saved a lot of lives and also have kept our vulnerable patients at home. And so it's difficult to know what is the real incidence of COVID-19 in rare diseases, because most of our patients have been safe and have not been in contact with the virus due to all these measurements to keep them at home. Next slide, please. In terms of the organizational impact of the pandemic in our work, obviously we have to change the guidelines of infection prevention and control very quickly, not only from inpatients with changing the flow of the patients within the hospital and how the patient have access to radiology or other tests, but also in outpatients. So now we don't have the same capacity in clinics to see as many patients as before. The waiting rooms have changed. The time that we spend seeing inpatients and outpatients has changed due to the PPE and the extra cleaning that we have to do. So everything is much more time consuming than that was before. Obviously, they're having staff shortages due to redeployment, sickness, stress, and there has been a huge impact in cancellation of clinic for a while. And now we are at the part of the restoration plan where we are allowed to bring some patients for face-to-face consultation and do CT scans or lung capacity tests. But obviously that is taking long, and there is a huge backlog in tests. That has also given us the opportunity to use technology much more than before, as we are doing now with this conference. But obviously it's challenging to assess a patient and break bad news about diagnosis or discuss escalation plans or complex medication over the phone with the patients that are unable to attend. And we have also have a significant number of patients that are reluctant to come to clinic and to come for investigation. So we are seeing also a significant delay in diagnostic of all respiratory disease, including rare diseases. For instance, we are doing satellite clinics with other centers for alpha-1 antitrypsin deficiency, and that has not been happening for a while. And also all our patient support groups have been cancelled for more than 1 year due to organizational issues, but also patients were not so keen to meet with others, obviously. That has also accelerate the implementation of technology for these kind of things, and the patient support groups has become more in use to use FaceTime or Zoom meetings for their support groups also. Next slide, please. And also something else is now we have to run also a post-COVID clinic. So we have to accommodate all this new cohort of survivors of COVID in our clinics because they have other needs. So I would like to do a brief comment about our post-COVID clinic. So we started this clinic in May. We were concerned that the patients surviving COVID may have a high incidence of interstitial lung disease because in other coronavirus outbreaks that was the case. So early in the pandemic, we, as the respiratory department, decided to try to follow up these patients with CT scan, lung capacity test, X-ray, to identify the evolution to fibrosis and being able to provide some treatment, despite, as you know, there is no guidelines or evidence about treatment for them, unfortunately. So our clinic includes a chest physician, that is myself, a respiratory physiotherapist, an occupational therapist, and a clinical psychologist. And we are doing phone consultation and face-to-face clinic. I would like to give a positive message about COVID because obviously there is a huge mortality. We have lost a lot of people in the way. But in my experience with probably 600 survivors of COVID, more than 75% of the people who were admitted in hospital with COVID are fully recovered 8 weeks later with a normal X-ray. The patients complain of fatigue, stress, and multifactorial dysfunctional breathing. That is one of the main components of what is called persistent COVID in some countries or long COVID in others. Next slide, please. So the underlying mechanism of pulmonary fibrosis in patients with COVID is similar to what we have seen in other viral pneumonitis and other acute interstitial pneumonia. So if the patient develop a diffuse alveolar damage that in most of the cases resolve, especially now that we are using steroids, but some of the patients develop organizing pneumonia, microthrombi that can cause pulmonary embolisms, and a progressive fibrosis with histological and radiological pattern of NSIP or UIP. The incidence is unknown, but it seems that it's less frequent than in the MERS outbreak. But considering the numbers of COVID cases, even if the incidence is less than 5%, we are facing a huge number of patients. So IPF, that is one of the most common rare respiratory diseases, may become not so uncommon now. Next slide, please. So most of the interstitial lung diseases are mostly idiopathic. There are some that are triggered by drugs or by some occupational exposure, rheumatological conditions, but in a significant amount of patients, we never know which is the cause. But in during the COVID pandemic, we are seeing different subtypes of interstitial lung disease. At the moment, we only have some evidence of the use of steroids and interleukin-6 blockers in the acute COVID pneumonitis, but there is still no evidence of the benefit of antifibrotic treatment as we use in idiopathic pulmonary fibrosis. It's too early to have this evidence because we are just 1 year after the first cases arrive. So we are quite limited in the treatment that we can offer these patients besides steroids. And the natural history and prognosis is unknown, again, because it's too early to see. The first survivors are now arriving to the first years after the acute episode. So there is a lot of questions still pending. But my impression is the complications are not as frequent as we thought in March 2020. Next slide, please. So in terms of the impact of the pandemic in the research and the workforce, the research, all the resources for research that we had were redeployed into COVID research, and that has been very successful. That has allowed us to have evidence that the use of steroids can be helpful, and tocilizumab, for instance, and also the progress with the vaccination trials. But most of the non-COVID research has been stopped or slowed down in the clinical, in the hospital setting for a while. And also the flow of patients has changed, not because of the new IPC guidelines, but also because of the reluctancy of the patients to attend if that was not strictly necessary. And also the time to do everything has increased due to the IPC limitations. There has been staff shortages due to disease and also redeployment. Most of our nurses were moved to respiratory or the COVID units or ITU. And now we are in the process to restore all the non-COVID research, but it's going to be a slow process. And unfortunately, it will take months to recover the level of activity that we have in research prior to that. So myself, I've been only doing COVID for the last 15 months, so I have little time to do anything else. In terms of the workforce, obviously there has been an unprecedented pressure, and I'm sure you are all aware of that. And there has been a different situation compared with what we were living in hospital before, because the perception of our own risk and the risk for others, the lack of rest, the stress, and very traumatic situations, seeing so many people dying around us, and how limited we were in terms of treatment and resources. We are now restoring the non-COVID activity, but at the same is difficult. It's difficult to organize, and again, the technology is helping us a lot. As I said, so we are doing much more meetings online, and it's easier to share experiences with other colleagues about COVID and non-COVID with all the systems that we have now in place. For instance, this app that I learned to use today, the Starleaf that we are using now. According to one of the surveys that the British Medical Association has done in the UK, approximately 44% of the doctors are saying now that they suffer from depression, anxiety, or stress symptoms associated with the pandemic. So this is obviously to be a problem for us to keep going and try to recover the backlog of non-COVID activity that we had. Next slide, please. What are we doing to support the patients with rare lung diseases with regards to COVID? So some of the registries that probably you are already aware of, the bronchiectasis registry, the European Alpha-1 research collaboration, the cystic fibrosis registry, they have all studies in place to identify the cases, the patients with these diseases that have suffered from COVID, and see if the natural history of COVID or the mortality rate or the complications is higher in this population. So far, because the patient has been isolating and shielding, the incidence is small. So that complicates, as always, any research in rare diseases, because there are always a small number of cases. There are some reports, some case report published about COVID and bronchiectasis and cystic fibrosis, but we cannot have any conclusion yet. There is increasing evidence about the protective effect of steroids to severe COVID disease. And with this regards, most of our chronic respiratory patients, a significant number of them are on steroids. So it seems maybe some of them may have had that protection because they were on steroids due to their other comorbidities. There is an exception that is the common variable immunodeficiency. So there is some evidence that's because these patients cannot produce a very strong immune response, they may be less likely to develop severe pneumonitis. They don't produce these cytokine storms and this excessive inflammatory reaction in the lungs. So their immunodeficiency that may be more vulnerable to infections in general may have protected them from having severe pneumonitis. Next slide, please. So in summary or in conclusion, virtual consultation and scientific meetings is something that COVID-19 has accelerated us to getting used to do that. I don't know if that will become the new standard and we will not have the opportunity to go to your lovely city of Rome for the next rare disease conference, but also facilitate the participation of more speakers and a higher number of attendees. I think it's positive that the social and peer support has progressed and has not stopped during the pandemic, but obviously there have been a huge barrier. It's also good that we have learned to be much more flexible in the way we work and in the way we live, and we are more multidisciplinary, and we are all learning new skills and start feeling more comfortable out of our comfort zone. Communication of science, something positive, in my opinion, is now the general public is more aware of how research works, more used to hear scientific news on the daily news. And if we manage that well and we can get more implication from the general public in science and research. Again, just a comment about the resources planification. Restoration of non-COVID activity is challenging, and adding the cohort of COVID patients with all the long-term complications, despite the number is not as big as we thought initially, is going to be challenging for the next years. And that's all I wanted to share with you. Thank you very much for your attention, and I'm happy to answer any questions, but I only have 6 minutes more.
Thank you very much, Dr. Lara, Beatrice. We are also close because we are in the same scientific society, ICORD. I would like to remember that, there is a society for rare diseases, which is called International Society for Rare Diseases and Orphan Drugs, and we are both members of this society. Thank you very much. Your presentation has been really excellent because from a medical point of view, and also from a social point of view, you gave us many information, important information. So I have a question, if possible, before leaving. You mentioned before about the post-COVID clinic, which is a great initiative, of course. My question is, in mild cases of COVID, positive COVID, do you observe also this fatigue, these symptoms, or are less present, let's say?
Though interestingly, I think the incidence of fatigue and stress and breathlessness in my cases in the community may be even higher, because what I see is the patients have a lot of uncertainty and stress, being at home feeling unwell, and that has triggered them to be more symptomatic after that. What we are seeing very interestingly is a lot of patients that were in a breathing pattern that will be physiological during the acute state of the disease, that is mainly breathing with using the accessory muscles and using less the diaphragm. They keep with this pattern after that, and they become breathless and tired easily because they are breathing in an abnormal way for daily basic activities. We call that dysfunctional breathing, but it was not dysfunctional when they were ill with pneumonitis. It has become dysfunctional to keep that breathing in that way for weeks. And in that respect, the role that, or the work that our physiotherapists are doing, helping the patients to relax and breathe using the diaphragm more than the upper part of the chest, sometimes is a massive relief just with the first session of physiotherapy. And we are seeing a lot of people coming from primary care with that problem. So this fatigue is stress, emotional and physiological, and a component of this dysfunctional breathing.
Thank you very much. And in the meantime, I would like to ask if among the participants there are questions. We can open the microphone, please. If you have questions, write in the chat. You want to ask something to Dr. Beatrice Lara because she has to leave in few minutes. In the meantime, that somebody will write some question. I would like just to comment about the cystic fibrosis registry, European cystic fibrosis registry, which is very, very important because, I can follow. It's a federated system, you know very well. And Italy has also the Italian cystic fibrosis registry, which is coordinated by our center, and this a disease registry, meaning that collects many data. It's not just following a data set, a minimum data set. No, it's exactly a disease registry. And we could follow the patients. So in the first wave of COVID, we had a few patients with COVID, few patients in sick with COVID, but in the second wave, they increased a lot. So now there are several publications at European and the global level that cystic fibrosis may be, at risk, let's say. It was not the same in the first wave. It was not the case. Is it also for you, this?
Yes. The cystic fibrosis registry was one of the first in respiratory diseases and has been very successful. And I think it's probably the gold standard of registries in respiratory diseases. And the disease and alpha-1 are not so developed. No. But there are initiatives to collect all the information about the COVID cases. And probably it's easier for us in respiratory because we are used to collect information about infections and things. So it will be easier than for others. But yes, so I think probably some communities have relaxed and get out more, or this fatigue about lockdown. So maybe the patients that were shielding at home more carefully in the first wave are not shielding in the second one, and that might have increased the incidence.
This is our data, and there are now several publications at Italian and Europe, as well as, of course, European level. It's true. And it's true that this registry is very, very important. It's used also for post-marketing surveillance right now. Because it's very, very accurate. So there are not questions for you, Lara, Beatrice. And I would like really to thank you so much, because I know that your time is precious for patients. You are really, taking care of patients. So thank you very much for being with us and sharing this important information. We will see you in the General Assembly of ICORD in few days. Thank you so much, Beatrice. Okay, so then we continue with the next presentation. It's my pleasure to introduce a young medical doctor, Ugolin. We are proud of you. And we will speak about COVID-19 and rare diseases, a global perspective of diagnosis, research, and care during the emergency. The Clinical Research Global Program in Rare Disease Fellowship Experience. Barbara is a medical doctor, maternal child department, USL Toscana Centro, but she has a lot of experience also in the USA, in particular in Washington and Boston. So, Barbara, the floor is yours, please. Finally, we can see you, because last time we had some connection problems. Please, go ahead.
Hello, everyone. Can you hear me okay now? Okay.
Yes, we can.
Okay. Good evening. Hello everyone. I'm very happy and thank you for Domenica Taruscio for the possibility to be here today and sharing with my experience during my clinical fellowship in clinical research program of rare disease at Washington DC Institute of Rare Disease. Next, please. During my experience, last year is very particularly because the COVID has had a serious impact on the life of the patient, a rare disease patient, and particularly for me because my patient are children and adolescent patient, and the impact on their family, in their lives, and their caregiver is very serious and very problematic. For first, uncertainty of situation about the effect and possible effect of COVID disease on different rare conditions and with possible consequence. The second, the discontinuity of therapies, treatment, especially for the in-person visits, for ambulatory treatment, for in-person follow-up, for the rehabilitation center, rehabilitation treatment, for example, speech pathologists or physical activity. Third, and the pharmacological response to COVID treatment, because the COVID disease is a new disease and the treatment is experimental. Four, but most important, and the risk for the caregiver, because the caregiver is the center of the life on rare disease patients, especially if it's the children, on the adolescent, on young person with the rare disease. And psychological effects on lockdown, especially for the children and the young people, the young person with the rare disease, for difficulty of communication, of distance didactic with different technological instruments, but especially for the people with special needs and educational special need was very arduous. Next, please. In my experience during the fellowship program, the most important aspect is next, please. Okay. I have been involved into a fellowship dedicated to diagnosis, research, and treatment of rare disease, especially for the inherited metabolic disorders, lysosomal storage disease, neurometabolic disorders, and for the rare form of myopathy. And during the second and third phases, actually, really, a pandemic, I have been involved in Italy in the project dedicated to my Italian patient, pediatric and adolescent patient with the rare disease, especially with metabolic rare disorders, and focused on the very problematic situation to transition rare disease patient from pediatric patient to adolescent patient versus adolescent and young adult with the rare disease. And I'm involved into program of the prevention and surveillance and management of birth defect supported by an health promotion and prevention project with help of the telemedicine and the teleconsulting, called by Futura project. And this is the flyer of the project of surveillance and prevention of birth defects, dedicated to a family with a couple, with the people with the antenatal care with an inherited disorder history. Next, please. In the next month, one of the most important part of my research, we focused on research in rare disease and impact on rare disease of COVID-19, particularly for the rare form on neuro-COVID in pediatric patient, in patient with progressive history of rare disease or inherited condition, and in patient without rare disease progressive. Next, please. During my experience and last year, I referred to different surveys dedicated to a special need of people and family with rare disease. Particularly, I referred to a survey of North American organization dedicated to rare disease, and for Italy, the survey realized in collaboration with UNIAMO and National Health of Rare Disease. The most important aspect for to global level for the difficulty of people with the rare disease to visit in person, for the access to the hospitalization, to in-person assistance. Next, please. The reduction of diagnosis between 50-17 less visit at global level and visit for a diagnosis, especially for the first 8 months of emergency. The access to the person to service of the hospitalization, particularly in Italy, with the problem of the closure of the many ambulatory service. And actually, there are many criticisms about the continuity of service in person, and many criticisms for the prevention and good practice about and surveillance about defect. In fact, this practice have been reduced. Only 30% of couples declared support about this program of prevention of prenatal genetic counseling, and difficulty to management, indifferent treatment. For example, evident for the dietary management for pediatric patients, especially for the compliance, for complication due to the lockdown, for a social and family complication to management this treatment. Next, please. During last year, I've been involved into beautiful challenge dedicated to the use of telemedicine, the application to the telemedicine in many fields, for support the patient with rare disease and the family with the rare disease, and particularly with the telegenetics. Next, please. Telegenetics and especially for the prenatal diagnosis dedicated to a family, postnatal diagnosis, and telemonitoring and telemedicine at home, teleassistance at home, for improvement the treatment, for counseling, for support the doubt about symptoms, telemedicine and telemonitoring in antenatal and perinatal care. With this program and the Futura project, improve the quality of the assistance and birth defect prevention in more of the 56 cases during the COVID-19 emergency. For example, for management, for early diagnosis of the diabetes, gestational diabetes, and the effects on neurodevelopment, fetal neurodevelopment, for the early screening of possibility of mutation, for management, dietetic management for the mother with an inherited disorder, and for example, for the phenylketonuria, with the major compliance for the dietetic treatment, for dietetic treatment and therapy, very most important for prevent the possibility of embryopathy. Next, please. In my general experience during last year, the use of telemedicine for the support of my patient, pediatric patient, children, adolescents with rare disease and their family was being very, very positive. In 6 cases on 10. There was a great compliance, a participation. It was the complication due to a COVID was and actually is a difficult to in-person visit and communication and to but at the same time the use of telemedicine and the digital device improvement during the months, during the weeks, improving the follow-up, improving the participation, the compliance of the pediatric and the adolescent patient, their caregiver, but also the autonomy of children and the adolescent, with participation in improvement in the treatment, with a sort of the patient engagement. An example, practical example of my fellowship experience at global level between USA and Italy. It's a relative to ketogenic treatment, medical dietetic treatment for McArdle disease patients and thyroid disease patients, particularly 2 brothers, 2 myopathy, very uncommon, and a very very challenging for diagnosis and for the treatment of success. Next, please. During my fellowship in this beautiful experience, I improved and I learned the methods of differential diagnosis for the undervaluated and uncommon forms of glycogen storage disease, particularly for the McArdle disease, glycogen storage disease type 5, and thyroid disease, very uncommon, estimated 200 people in all over the world, but very under-evaluated number. Thyroid disease, glycogenosis, glycogen storage disease type 7. First, from collect the symptoms with call by phone, with and telesupport, telemonitoring, and different symptoms, especially after the exercise, and monitoring enzymatic parameters, and the observation, especially the early symptoms, pain, early respiratory insufficiency, especially in the early infancy and in newborn in little cases, fatigue during early infancy, exercise intolerance, and particularly effect often underevaluated on the second wind. With almost 3 symptoms, is requested the genetic test. For many colleagues, the diagnosis of these 2 types of myopathies non considered. Next, please. The most important challenge for this study, the most important challenge for the study is the separation of the common symptoms and particular symptoms. The common symptoms: fatigue, exercise intolerance, pain, high level of creatine kinase, blood urine, and early low lactate levels, and involved if the disease undiagnosed in rhabdomyolysis and kidney failure. The difference between a 2 pathology and the 2 types of myopathy from other myopathy, more common, an effect of second wind typical of the myocardial disease only, and the increases of lactate level only 20-30 minutes after exercise in thyroid disease. And the early genetic test after the observation of 3 symptoms almost of the mutation for phosphofructokinase and for the thyroid disease, and for the myophosphorylase for myocardial disease. These 2 imaging, one for the myocardial disease represent and the animation dedicated to the patient community with myocardial disease, for recognizing a possible early symptoms, for the help to description for the for help the community of the of colleague to for improve the differential diagnosis of this type of myopathy. And the second figure dedicated to thyroid disease, Together We Are Stronger. This is a group, a social media group, when the community, work community of thyroid disease people, especially young adults, sharing the many information, many information about their pathology and disease and possibility of treatments, and many challenges dedicated to a physical activity and exercise activity with athletic challenges, for example. Next, please. my fellowship focused on, in particular, in a diagnosis of cases of myocardial disease, and one most success history with the support of telemedicine and telegenetics device, and with the collaboration of my colleague in Italy and the United States about and particularly cases of the myocardial disease in two children, Brian and Eliza. Two children, Brian and children of 9 years old in Providence, United States, and Eliza in Siena. Next, please. At the same time, in collaboration with the Nutriceto program dedicated with collaboration of University of Salerno in Italy, the School of Medical Medicine and Pharmacy, Nutriceto program, and in Nutriceto lab, with a possibility on the realize a study dedicated to medical dietetic treatments and medical dietetic therapy, particularly the ketogenic dietetic treatment. In particular, my studies dedicated to undiagnosed myopathy, glycogenosis type 5 and type 7. With telemedicine support for the follow the progression of the therapies. Next, please. The example of the history of Brian and Eliza, particularly now Brian, unfortunately, is in hospital in Providence for the not for the myocardial disease, but for the consequences of COVID disease and the long COVID and multi-inflammatory syndrome with kidney failure and dialysis treatment. But the history of Brian and Eliza were history of success, because during the last year, Brian, 9 years old, Eliza, 11 years old now in Siena, the condition of these two children have worsened with pain, fatigue, very difficulty of movement, exercise intolerance, particularly reduces during lockdown, but increased during the last summer and the school during the school activity. The early diagnosis with initially clinical exam for the myopathy, excluding the glycogenosis storage disease screening or genetic test or differential diagnosis. Many unevaluated symptoms, for example, the increased level of the creatine kinase for the blood cell in urine, and nausea and vomiting, and unfortunately the next step, the emergency hospitalization for very chronic pain and kidney issues and respiratory issues. Next, please. In this research, in these cases, the use of telemedicine and the multispecialistic approach, sharing my idea, my hypothesis of diagnosis with my colleague, were crucial for the correct diagnosis and for the tempestive treatment for prevent kidney failure and rhabdomyolysis. Particularly the early analysis of the symptoms. Elisa was a dancer, for example, and now needed a wheelchair to get around, to possibility of movement. Brian was a basket player and with the difficulty of movement and autonomy also. The early diagnosis excluding many myopathy. And second step of diagnosis, after consulting with the family of these two children and of my colleague, involving to test for the creatine kinase enzyme, for ammonia levels and for lactate levels. The next step, the genetic counseling for glycogen storage disease, the type 5 and type 7, sharing information and the possibility of a new genetic test specific for these two forms of myopathy. And early hospitalization for the for improvement of the diagnosis and following the patient, especially for the application of early treatment. In this cases, for the improvement, the degeneration and the symptoms. For first the pain, the chronic pain. Next, please. Particularly, I'm very happy for the success of the history of Elisa. This is photo. Elisa sent me this photo, and thanks for courtesy of the dance school of Elisa and for the parents or class of Elisa. And Elisa is turned to the bar, and very, very beautiful history. Elisa, after 3 months, improved the symptoms of the pain, and after 6 months of ketogenic therapy, improved and the symptoms as fatigue and exercise intolerance. Next, please. We have realized this project of the relative to ketogenic therapy for treatment of glycogenosis with great success. We support the telemedicine. This project named Keto Kitchen, and the most important aspect is the management and follow-up of ketogenic dietary treatment therapies with support of digital health, and for improve the compliance, for improve the autonomy of the children and of the young people, young person that need this therapy, because this dietetic treatment now are the unique treatment for different metabolic disorders. And this program with telemedicine, support and communication with social community of myocardial disease with social media, and this virtual cooking program for involvement of the patient, for improve the compliance is a big success. Next, please.
Barbara,
Sì.
may I? Maybe if we could speed up a little bit because there are several questions for you and we can open the discussion. Yeah?
Chiudo.
No. You, if you want, you can continue, but just, if we can, because it's 4:30 already. And
only two.
Please,
Okay.
go ahead.
A new challenge, an early diagnosis for infant ultra-rare forms, so glycogenosis type 5 and 7. The early infant diagnosis of myocardial disease and thyroid disease are very, very uncommon. The symptoms are associated with hypotonia, flappy infant, respiratory issues, and possible neuromuscular disorders. And for the first year and the normal level of the creatine kinase and different progression on neurodevelopment symptoms and kidney failure. And unfortunately, death for respiratory failure, but not for diagnosis of myocardial and thyroid disease. And we have developed with a pilot program of early screening in a preterm birth with MRI College of the two forms of glycogenosis ultra rare for early infant. Next, please. Actually, and in the next future, my research focused on the rare form of COVID-19 in neonatal and pediatric patients, especially about neuro-COVID and neuroinflammation after the COVID infection, COVID disease, and the involvement of multi-organ failure due to MISC as a consequence after 4 or 5 weeks after the infection in pediatric patient. Observed 15 patients with progressed pathologies, inflammatory symptoms, and 5 in particular with neuro-COVID, and 10 pediatric patients without progressive pathology with MISC and with neuro-COVID, especially in areas with many cases of coronavirus. Thank you so much for your attention.
Thank you very much, Barbara. Thank you. So I invite Marta to open, and show all participants. There is a question for you, Barbara. Oh. Close the microphone. Marta, close the microphone to everybody, and we can open just for the answers. So there is a question for you, Barbara, from Elvira Martinez from FEDER about, can you read the chat? Should I give the floor to Elvira? Elvira?
I can say it myself.
Yes.
It was a question, but also a reflection, because we were thinking a lot about it here in FEDER during the pandemic. It's you told us that from your point of view and your experience, telemedicine has been very important. So I would like you to share your thoughts about how do you think telemedicine and e-health are going to evolve in the short term and mid-term, and do you think this is a positive thing that the pandemic could have brought us? At least in Spain it has been a bit, because we didn't have anything or almost anything about that. So it's the difference. What do you think?
Barbara, can you answer? You don't have the phone?
Okay.
Okay.
Ask about telemedicine. Okay. I think that now the telemedicine is not complete solution, but is very important instrument to improvement our work with and the rare disease community, because at the same time support and our difficulty to visit in person and to distance, but for me it's very important, very challenging is the continued use of telemedicine support for the following the patient during the phases, for example, at home, during the particular treatment, with a continuous counseling for possible doubts or difficulty, for improvement the patient engagement. For me is an instrument, but at the same time is our challenge for improve the quality of life or care of our patient, of our communities, and for the involvement into the treatment, into the study, into the improvement, the social and the practical aspect also, especially during the situation of emergency, as now, for example.
Yes, if I can add something, we had several webinars on this issue of telemedicine, e-health.
Very important.
Right, very important topic. And during this year, because it's almost 1 year that we are organized these webinars. So we invited also the director of the National Center for Telemedicine, which is inside our institution, Dr. Gabrielli. And really there is a great need to increase telemedicine, but we need to use it in a structured way with specific rules, and also following, for example, ethical rules, consent, and so on and so on. So my perception is that yes, of course, it's a useful tool, very, very, very good, if used in an appropriate way, but cannot be, of course, the medical, the doctor and patient relationship cannot be cancelled, of course. So I agree with Barbara that right can be used very nicely for a follow-up, for following the patient. For example, now we are trying also to use it in a systematic way for the rehabilitation. But you need anyhow the contact with the person. You need
absolutely
to absolutely. You cannot cancel this part. I would like, because I see here Dr. Macucci. Would you like to comment on this? Because please. If you want to comment, I know that you are supporting very much this. Please.
Oh, yeah. Can you hear me?
Yes, very well.
Yeah, very well.
Okay. I want to give my compliments to Barbara for her excellent presentation before all.
Thank you.
And I have two things to say. I think that the growing importance of telemedicine induced by the pandemic is a real progress for the level of assistance for rare and, above all, undiagnosed patients. This is a very important item in my opinion. And the second thing, I hope that this crisis could lead to a better knowledge of the world of rare diseases, and to highlight the need to have more and more services dedicated in exclusive way to this problem in the public health service. What do you think, Barbara?
I think that the very problem this in Italy, especially for the bureaucracy, these practical and technical obstacles, but for me is telemedicine and different declination of telemedicine, no, telegenetics, telemonitoring, teleconsulting are a possible instrument for a very public health action. For example, in the activity of multi-specialistic prevention, counseling for different specialized doctor, for people with the difficulty to access, for example, for the center of diagnosis, for geographic distance, for physical difficulty. The telemedicine, for me, is an instrument fundamental for an equity in health, for an equity services, but it's a very hard. It's very
lost. I think she's lost. Okay. Barbara, we have lost your last words because you stopped for a while.
I repeat.
Yeah, the last part of your speech.
Can you hear me now?
Yeah, I can hear you. You was saying that it is an important tools, and for all the kinds of things such as geographical distance and so on.
Okay. This part. Okay, to repeat from this part. Okay. Okay. For me, I'll resume. For me, the telemedicine is an important instrument in the public health. In the public health organization, because the support to the rare disease community, diagnosed rare disease patient and undiagnosed, especially for undiagnosed disease patient, for their community, for their family, because the telemedicine instrument, telegenetics, teleconsulting, and different device for support the telemedicine is an instrument for improvement the quality of life of the patient, especially for the patient with many difficulties, social difficulties, to access the public health structure, for the center of diagnosis, center of therapy, for the geographic distance, or for the physical difficulty. Now we, as community, like community of doctors, scientists in rare disease field, the challenges now is improvement the instrument for the realize the good practice for improvement the quality of life, the community of rare disease people, for involvement the rare disease patient and their family in the different steps of diagnosis, so the patient engagement, the treatment, and the sharing with a possible doubt or ideas about improvement, very difficulty, for example, social difficulties, because bureaucratic difficulties, and we have a arduous challenges, but we, my point of view, it's a the telemedicine is fundamental, is an instrument. Now is the instrument fundamental. At the same time, the diagnosis, the molecular instrument, the clinical research, and the training about a rare disease for our community of scientists.
Yeah, I totally agree with you. So we can use it as a useful tool in order to improve equity of accessibility to services, because as you underlined, for example, there are several problems, distances or poverty and many other things. So we can really use this tool for the benefit of the community. And in addition, I think we can use it for training for scientists, young or not young scientists, for medical doctors, for peers, and everything. So I think that it's a powerful tool that we should improve more and more, and we should use it more and more. I would like just to remember for the Italian people, but maybe for the benefit of also from others, that in Italy in December 2020, the Stato-Regione conference approved an important document on e-health. So that means that now it's officially can be used officially and can be also used following the rules like a medical act. So, and right now, our institute is working on the documents on rehabilitation. So I think that it takes time to structure these initiatives, but it will follow. It will go. Other suggestion. So, Elvira, are you happy about this answer? And also, Dr. Macucci, maybe Dr. Macucci would like to say where are you working? Because it's nice also to build this community, you know. Please.
No, there is a noise, Domenica. I don't hear your question.
Oh, okay. So I would like to introduce yourself and where you work, because you are.
Oh, thank you very much. I'm in this time. I am in Castelfiorentino near Empoli, and I am in my room, which is the main work that I do is in this room, because this room is the rare disease service of our neurology, and this is a very simple organization. This is a very simple organization dedicated to the rare disease of the nervous system. And our work is very simple to describe. We analyze the patients without diagnosis or with diagnosis of rare disease, and help these patients to do what they need with our resources to the first level in Empoli. If is necessary a second level of assistance or diagnosis or therapy, we send the patient exactly where he or she needs. That's right.
That's very important.
This is
thank you, Marco. Yeah. Because, in the system, I think we need a lot of points like yours, because if you don't know how, there are a lot of people without any kind of diagnosis, and we don't know exactly where to send them. Because if you send them to one of the ERN, for example, that is specialized in just one of the branch, in just one of the group of diseases, the risk is that his or her disease is not the one, and so they just send them away another time. Yeah. And so I think we should have 2-3 points of access in the system, in which a multidisciplinary team could take care about the people without a diagnosis, and just look at him or her with an open mind and try to find the right group of rare disease in which to insert the person and to send to the specialized centers. Because I think I'm seeing a lot of people in Facebook, for example, if you are socialized, they are sending us also clinical clinical papers, and they, okay, I have this kind of symptoms. Do you know if other people has the same, and which kind of disease is this? And they don't know where to go. And that's I think one of the lack of a system, just one of the lack of a system. And teleassistance and telemedicine is very important, even if it's just one tool in all our world. Because we have, I was thinking just before that 20 years ago, we didn't have any kind of smartphone. Now we can't live without a smartphone, without a connection every day, 24 hours a day, and so on. So I think telemedicine could be another tool that we can develop, and we have to develop it with some kind of rules also. And I think in 10 years, we couldn't think of a world without a telemedicine. I think it will last only 10 years, and then we didn't think about, 10 years ago, we didn't have telemedicine. But how can we imagine this? Our sons, our daughters, it will be very normal to keep in touch with the doctor with an app, for example. I think it's not so fantascientific. We could not imagine it, because we are very used to have a touch with a doctor, with a clinician, and we think it's impossible to don't have that. But I think our daughters and sons will see the world with different eyes, even if it's for us is incredible, and I think it's also very rude or cold, a cold way to interact. But
if I can comment you, I think that we need a completely different way to examine the patient without a diagnosis. So, in short, we must do every time a sort of grocery list of her symptoms, her signs, and her neurological points and examination and so on, because this is the best way, in my opinion, to organize diagnostical possibilities. And there are two things to say. The first, we can use many expert systems for diagnosis online that now could help us to clarify the differential diagnosis, you know? The second thing about neurology, we have many tutorials dedicated to the neurological examination at distance. Yeah. We can do a near complete neurological examination at distance. And I think that we must not have a prejudice about the teleconsultation, because in many specialties, the neuroconsultation is nearly complete. And we must use this possibility very often because it's too easy for the patients.
So I would like to add finally, because as Marco, Dr. Macucci knows, and other colleagues, we are trying to do our best to organize this undiagnosed disease network international. And Marco asked several times to join, how to join, and so on. So I can update now directly that this is an international network, of course, and so several countries, now we are 24 countries, trying to work together using the same criteria and so on and so on. But what we are doing now, which is new, it's to start what you asked several years ago to me. A common basket, let's say, of experts to make the first examination through telemedicine and so on. So I will update you as soon as we have this kind of opportunity, because we are discussing. It's called educational. There are two different groups. One is educational group for young people, young scientists, and so on, and the other one is diagnostic group. So I will update you as soon the structure will be more solid, let's say, because now there is still, several discussions among experts how to do it, which is the key, the entry point, if one country should have just 1 point or more, and so on and so on. So there are several discussions, but because it's a multinational, let's say, initiative. But I think that we can contact you offline, and you are welcome to join our community, Marco.
Thank you so much.
The same for Barbara, of course. The same for Barbara, because we are looking for young medical doctors and experienced doctors like me, Marco. So, of course, these webinars, I think, should really help the community, should help to connect each other and make more connection. Who wants to comment? Tony, are you still with us? So Tony knows very well Italian also, Tony Monserrat? Yeah. You worked a lot, with us also in Italy.
Dimmi.
Cosa ne pensi della telemedicina?
No, sono assolutamente d'accordo. Infatti ci sono, lo sai bene, in questo nuovo periodo dal bilancio della comunità c'è stata lanciata una nuova agenzia e un nuovo posto nel bilancio dedicato integramente alla telemedicina, e particolarmente quello che c'è stato lanciato per la rete europea di referenza, IRN, mi sembra importantissimo, perché c'è stato fatto anche cercando una coerenza di non avere diversi sistemi per fare tutta questa trasmissione digitale, tutta questa approccio alla telemedicina. E la telemedicina è anche una parte importantissima di tutto quello che costituisce la medicina personalizzata, perché ci apre anche delle porte straordinarie per avanzare in questa parte. Per me è uno dei grandissimi punti da sviluppare in questi prossimi anni, anche perché abbiamo tutti imparato nel 2020, nel 2021 come fare della telecomunicazione e come fare delle telemeeting e come fare delle tele. Adesso facciamo una grandissima parte delle nostre attività nella telecomunicazione. È assolutamente logico che la telemedicina faccia parte di queste grandissime possibilità che si sono aperte adesso, credo.
Grazie, Tony. So I would like really to remember again that Tony Monserrat worked many years in the European Commission, and he's well experienced, as you can say. And we worked together many years, myself from the Italian point of view, and Tony, of course, in the task force for rare diseases, a European level, and Tony was as a commissioner. So we worked together in the task force for rare diseases, but also in many projects, such as Europlan, EpiRare, and others. We made the history of the rare disease, let's say, in Europe, right? Now we are following and we are trying to involve younger people with enthusiasm, yeah, yeah. And Tony, I hope that you will follow us, because it will be nice to have also you as a speaker in maybe in 1 month, because next will be only in Italian, but you don't have a problem to speak in Italian, as you could say. So I will invite you, maybe from your point of view, to give us a perspective, as you mentioned before in few words, about the new initiative at European level on rare diseases. This is your field, and you are very, very skilled, of course, on that.
With
if you
pleasure.
accept our invitation, I
With
can meet
pleasure.
you. Oh, okay, great. So this is very important. So thank you so much. And friends, if you don't have additional comments or questions, do you have other from the chat? No? So we can say it has been a really interesting webinar, very stimulating, very friendly, as usual, and maybe more than usual, I think, more friendly, because it's more informal. It's more informal, you know. I like informal meetings. I don't like, as Tony knows me since many years, I'm really happy when I can discuss free among friends, let's say, not in a bureaucratic language. So thank you very much. I think that we will see each other. If you wish to join us in 15 days, we will have a webinar in Italian. It will be concentrated on thalassemia, because of the Thalassemia World Day will be on May 8th. Our webinar will be in May 6th. So we will invite the patients groups, but also experts, and especially for the shortage of blood. So this is a big problem. So we will see each other then in 15 days. You will receive my email, our email. I would like to thank Marta. Are you here, Marta? Marta, here. So Marta is our is a scientist, is a psychologist, and she is the coordinator of the Telefono Verde Malattie Rare helpline, yeah? And she does many other things, many activities, including Europlan in the past, and now closer with a Spanish group. We are a team, we are together, let's join our effort. I would like to thank a lot Barbara for the excellent presentation, really excellent. I would like to thank
you.
Yeah, you are very welcome. Let's continue our collaboration, which is at the beginning. And I would like to thank also Elvira and Alba although we didn't see, but I know that Alba is very, very busy, of course. And congratulations, Elvira, for the excellent activity that you are doing, as I said, at the FEDER, but also as Aliber in Latin America, because I'm following you very closely through ICORD. And we are actually partnering there. So, and I would like also to invite, to thank Tony Monserrat, that I asked as a discussant, but he's a friend, so I can do it. And also Dr. Macucci and the others. And the last word to Annalisa. Please, Annalisa, you can close the session.
Thank you, Domenica. Thank you to all the speakers, because it was very interesting today. And this way to finish the webinar is so warm. And even we are not in person, but it's so nice to see you in face.
Yes.
Just in these small stamps in our computers, but it's so nice to see you. And thank you again, because we feel that rare disease is a special field in which you are, because you are a person with a rare disease, or you are a caregiver or something like that. But I think that all the people that are in this field are so fond of rare diseases, because they start to match rare diseases and they didn't leave them for all the life long. That is something much more than as a treat, but a promise. But of course, thank you a lot. Thank you to you all, and thank you to Domenica. That is so nice, and it's been so able to manage all these webinars. Thank you.
You know, I'm really enjoying. This is my life. This is my passion. You know very well, and I do it with really, joy. Let's say, let's work together and let's collaborate. Ciao, alla prossima.
Ciao.
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 Ciao, see you soon.
See you soon, Elvira. Ciao.
See you soon.